Welcome to Breast Intentions, the podcast where we take off the bra of expectations and dive into honest, empowering conversations. We're your hosts, Nadine and Cynthia, two Canadian girls who swapped snow boots for flip-flops in the Cayman Islands. This is your space to feel seen, supported, and a little less alone. So grab a cup of coffee or a glass of champagne and get ready for your weekly handful of truth, wellness, and empowerment. Today's guest is Dr. Mona Shah, a triple board certified cardiologist with a passion for precision and whole person care. As the founder of One Heart Cardiology in Florida, she blends cutting edge cardiac testing with holistic medicine to help women protect their hearts through every stage of life. Get ready for a powerful conversation about hormones, heart health, and healing from the inside out.
So today we have a very special guest who is Dr. Mona Shah, all the way from Florida. She is a holistic cardiologist and a triple board certified cardiologist. And one of the reasons why we wanted to bring Mona onto the show was there's, from the standpoint of midlife, women's health, menopause, we all kind of know that there's some stuff to do with the heart, but I don't think that we know enough in detail and actually how the heart is impacted and how it affects us, especially as women in midlife. And so I just wanted to welcome Mona to the show and have you do a little introduction on yourself and let us know all about you.
Okay. So I've been practicing cardiology for almost 20 years, and I got board certified in holistic medicine about 10 to 12 years ago. And then I got board CT'd and coronary CT and reading CAT scans of the heart arteries a couple years ago. So that's hence the triple board certification. I've been with a big hospital-based practice, like most specialists are, for that whole time, about 18 years. I left recently in January. I left that whole system because, as we know, I don't know how it is down there, but up here, you know, when you go in to see a doctor, it's 15, 20 minutes. Mm-hmm. You know, it's a lot of defensive medicine. If you want to, especially for specialists, it's very hard to get into. So you're waiting 3-4 months. If you want to see them for a follow-up, it's another 3-4 months. You really don't have direct access with the patients as far as if they have questions or concerns. You know, they're asking questions on the portal and they're getting answers from medical assistants, nurses, which is great, right? Mm-hmm. I mean, it's great that we have all those resources when you're in a big hospital-based system. But for me, practicing holistic cardiology, it just wasn't the way I wanted to practice medicine anymore. I was kind of overspending only 15 minutes with patients. The way I practice is a little bit different than just a general cardiologist. I really dive into diet pretty in depth, stressors, vitamins, supplements, you know, and then I'm also talking about the heart, right? So to do all of that in 15 minutes is as you can imagine, right. It's pretty clear impossible. So hence I left in January, started my own concierge cardiology practice, and it's been amazing.
I bet. Yeah. What did you say at the very beginning? Defensive medicine?
Yeah, so defensive medicine. So I feel like we've kind of come away from preventative as much as now it's become more, oh, I'll see you when you have a problem.
Yeah.
Right. So when you have high blood pressure, when you start having chest pains, when you start having things, then I'll see you. And then we'll start doing all of the things and the testing and all that. Right. So obviously, as doctors, we always have to practice defensive. If someone comes in with an issue, you know, we're going to try to solve it and fix it and do what we need to. But I'm very much about preventative. Like, well, what can we do before we get to that phase, right? A lot of patients, especially once they hit mid era of life, you know, 40 to 60 or so, their best friend just died of a heart attack. They were fine and then they weren't fine, right? And so a lot of people are getting educated, which is great, and they want to just get checked out. What is my risk, right? Because a lot of heart disease goes undiagnosed. You think you're fine, and then lo and behold, you know, you're not. So I really like focusing on that, the preventative aspect of cardiology.
And then the holistic side, holistic cardiology. That's very
Yeah.
new, maybe, I guess you could say, or just unheard of, because you're only one of 3 in all of Florida.
Yeah, as far as board
Okay.
certified, right? I think a lot of people like to, I think they're open to,
I see.
alternative practices. But I'm a very much, well, I want to do this the right way. So instead of just dabbling in it,
Go all in.
I got board certified,
Yeah.
go all in, let's do this the right way. And so, what it basically means is that, yes, it's kind of East meets West. So of course I do the traditional practices, here's your medications, here's your testing. But then I found over the past many years that more and more people just don't want a medication and then see you in a year, right? Well, what else is going on?
Yeah.
Why do I have this, right? What can I do naturally? A lot of people are shying away from drugs and medications and all this stuff. So that's kind of also where my role is. It's like, okay, well, if you do need medications, then here's the lowest possible dose that we can get away with, but we got to pair it with a better diet, sleep, maybe some vitamins and supplements, stress management, all of the other tools. To me, it's whole with a W, right? As far as looking at the whole body, not just here's your problem, here's your drug kind of thing.
So how long
I love practicing like that.
how long
Yeah.
do you spend with your patients when they come and see you?
So now it's 60 to 90-minute appointments.
Oh, that's awesome.
Wow. That's amazing.
Yeah, it's
Yeah.
great. And, I was taking care of almost close to 3,000 patients in my prior practice, right? And I have no intention of having that many patients, because the patients I do have, I want to give them as much as I can give them,
Yeah.
right? And if they have questions, if they have issues, something comes up, they ask a question to me, and I'm the one who gets to answer them, and I'm the one who gets to know what's going on with them.
Right.
So it's been
I
great.
bet.
I also feel like when you
Yeah.
have, as me, as a woman, maybe a woman in midlife,
Yeah.
knowing that you have, well, had, not currently, but you had, and other doctors have 3,000 people on their caseload, I'm not going to come in if it's something little, or if I'm not too worried about it. She's busy. I don't want to take her time. I don't want to bother. There's other people who are more sick. And so I might let it go longer then, and that might be the generation that I am, or because I'm a woman partly. But knowing that,
Yeah.
you're busy. So that I think
Right.
would take some of maybe that away from me, if knowing that, well, you have this more of a concierge business where model where you do take that time, you have less clients. So I might be more comfortable
And I
coming in
think
earlier.
Yeah.
I think-
I would hope so. And
Oh, I
yeah,
was
go
just
ahead.
going to say, I think that that's what people want these days now
Yeah.
too, is that emotional connection, that relationship, that they can actually come in with their list of questions and not feel like you can only pick
Right.
the top 2 and, that kind of thing. So,
Yeah. No, exactly. And that's what's been great. We're not rushed.
Yeah.
We're just talking. There's not like a room of patients waiting and the doctor looking at their clock or halfway out the door. And unfortunately, hospital systems, they're businesses, right? So it's kind of like for doctors, it's a huge overload, and see more patients, see new patients, see them faster. It's just kind of gotten, so I'm lucky / blessed to be able to, do this and, do it the way I want to practice it. So
actually, I have another question too, what was your reason for switching over? Like, were you burnt out?
So yes. Well, one reason was just kind of what I said, like to try to explain being the only holistic cardiologist in this whole area of Florida where I live, I had waiting lists for like 3 to 4 months. Right. And so and those are just regular visits. So like 15, 20-minute visits. Right. Then I would have only a holistic slot, which would be the time where I could spend more than 20 minutes. So though I had a little bit more time on those, my hospital system worked with me to make those slots available.
Oh.
So those were like 30 to 40-minute slots. But that wait list was more than 6 months because, right. And so And it's very frustrating. And as a cardiologist, if I see somebody, I order labs on you, I order your testing. Do you really want to wait 6 months to go
Right.
over all of
Yeah.
that? You know, no. And then also as a cardiologist, emergencies
Mm-hmm.
happen, right? I mean, people have chest pain. I got to get them in.
Mm-hmm.
I can't wait for 6 months. So then I'm squeezing my schedule to get these patients in to just, take care of them. And then I'm also trying to see just regular patients and trying to do it in 15, 20 minutes. So one part was just my back was kind of against the wall with I can't practice like this anymore, the way I practice medicine, right? So that was one. And burnout was very high, right? Because trying to do this 25 patients a day, going, and then you're answering about, 30 questions on your
Right.
portal from patients who have questions. It's a very high burnout rate, at least for what I want
Right.
to do.
Yeah.
I didn't want to just go in and say, here's your medication. You're doing great. Your labs look good. Okay. See you in six
Right.
months. Right. So.
So this was something that I didn't know, and I had just recently seen it circulate. Heart disease is the
Yeah.
leading cause of death for women. I did not know that. So
Yeah.
why is, looking into the heart and taking care of the heart and paying attention to heart health so important, especially for women in their 40s and 50s?
Yeah. So 1 in 4 women will die of heart disease, 1 in 30 of breast cancer, right? And so women, of course, everyone's like, oh, I don't want to have breast. No one wants any cancer, right? But women especially, are so fearful of getting breast cancer, right? But the death rate from breast cancer is almost 8 times lower than heart disease, right? And so there's several reasons, right, that women have more heart disease, especially as you get older, right? So we know, and I know we're going to talk about hormones in a little while here, but the estrogen in our systems, right, that we naturally produce up until, we start going through perimenopause, which we're all over the place. And then obviously when we're finally done, it's menopause. Estrogen is actually protective, right, of the heart in multiple different ways. And so that's, to me, the primary reason why women, it's almost triple the amount of heart disease as far as premenopausal versus postmenopausal women, right? And I think we're getting better at educating women. I try to do as many lectures, the American Heart Association, they're trying to put all this out there that, hey, you're more likely to die of your heart than breast cancer or really anything else, right? And so the education's going out there. But even then, if a woman has a heart attack or heart disease, especially when they're younger, 50s, 40s, maybe even early 60s, they're twice as likely to die of that heart attack than a man the same age,
Oh,
which is crazy, staggering
wow.
information, right? And yeah, and it's a woman has a higher risk of stroke when they hit menopause, right? A woman who has a heart attack is higher risk of having heart failure with a heart attack than a man. So, and why, right? So why are women who have heart attacks when they get older, or even in their mid-age, dying more than a man? And I think there's a couple reasons for that. One is, traditionally, if a woman comes into the ER with chest pain, right? And a lot of women don't have chest pain as their primary sign of having a heart attack. I saw a woman who was caught way late. By the time I got called on her, it was almost 24 hours that they hadn't checked. She was having abdominal pain. So she came in with abdominal pain. No one bothered to check her heart. She had risk factors, but abdominal pain, checking ultrasounds of the stomach, blah, blah. And then eventually someone got an EKG and she was having a heart attack. So, women also don't have the traditional signs. They still do, chest pain, which is what everyone worries about, but women more likely can have fatigue, right? How many women are
All of
tired?
them.
I mean, it's, all of them, right? So, they get kind of, or, oh, you're having a panic attack, they're winded more, they're a little bit more short of breath, they can have pain that goes into their back, et cetera, et cetera. So when they pop into the ER docs are getting better at, oh, this is a woman of the age and she's having these symptoms, let's at least do an EKG, right? So back 20 years ago, women were way later of getting an EKG when they rolled into the ER than a man. Women were way later at getting a catheterization and putting a stent in your heart than a man. Women were not getting on the appropriate medications. I mean, we were just kind of going under the radar, right? Even look at studies, right? Studies in heart disease back in the day were primarily men, right? And you know, we're not little men, right? We have completely different physiology, hormones, our arteries are different, everything is completely different. So I feel like we're getting better at educating, first of all, women themselves, like, hey, you're more likely to die of a heart attack, so pay attention. And doctors too.
Right.
You know, don't blow off those symptoms, right? Like, it's better to get checked out and say, yes, it was a panic attack. Yes, you're just getting older. Yes, you're just stressed out, whatever it is, then it be
So that. Is estrogen, or the loss of estrogen, directly related to heart disease, or vice versa, I guess?
Yeah. I mean, we definitely know that as we get older and our estrogen drops, heart disease increases, right? So there's definitely that correlation is there. Because what does estrogen do, right? So estrogen in our bodies, it helps keep our cholesterol lower. It actually helps insulin sensitivity, right? It helps with our arteries, actually. So estrogen in the coronary arteries actually helps keep it dilated, meaning you get better blood flow through them. It helps with inflammation. I mean, you could go on and on, right? So there's estrogen receptors, as we know, in the bone and the brain, and, you know, but as far as the heart goes, there's multitude of factors of how estrogen is protective. Okay. And then once we lose that protective effect and we're just kind of hanging out, then we don't have any of that, right? Women, often their cholesterol goes up, right? They're like, wait, I'm eating the same. I'm exercising the same. I'm like literally doing the same stuff. I've just gained 10 pounds overnight and my cholesterol's going crazy, right? So that kind of stuff, right? So I personally blame the hormones, right? Of the loss of hormones primarily, especially if women are kind of doing the same stuff as they were doing, and all of a sudden there's a shift.
So then does your focus then at that time switch over to support from a hormone perspective with your clients?
So I personally don't prescribe hormone therapy. I'll kind of write a whole list of my recommendations. And then I kind of, because most women here have gynecologists. But then again, I'm asking them, well, how does your gynecologist feel about hormones, right? Because as you know, I mean, a lot of gynecologists are, I mean, really, if you look at the hormone data, it's a mess, right? It's a disaster. So there's not like, okay, hey, if you have this, here's this. If you have this, you have this, right? It's all over the place. And so unless a gynecologist is very well versed in the newer data, then I kind of write everything I think. And I'm probably, you know, after opening up this practice, I love learning. I love educating myself. And so probably my next phase is getting some sort of specialized training in hormones so I can do that for my patients. I don't do it now. I know enough to tell them, hey, this is what I think you should be on. And this is what you need to talk to your gynecologist about. But yes, to answer your question, that's part of it. That's a piece of the puzzle. It's not the whole puzzle.
So then is it safe to say from a cardiologist's perspective that women need the support of HRT or bioidentical?
So great question. Again, every single person's different, right? So it kind of depends, right? So if you take a woman who has, you know, no history of breast cancer, and that's controversial too for hormones, right? It's a whole different conversation. If you take a woman with no history of heart disease or heart clots or, you know, any of the strokes or whatever they haven't had, we can talk about that in a second, but let's say you take just a normal, healthy woman, right, with no other risk factors, and she comes to me and says, hey, what do you think about hormones, right? So there's two things that I like to think about with hormones. Is one is how symptomatic are they first, just from losing their hormones, right? Like, are they sleeping? Are they not sleeping? Are they having the, you know, hot flashes, night sweats? Where are they with their weight? You know, sex drive, you know, vaginal dryness, all the symptoms, right, of that come along, brain fog. with perimenopause and menopause, right? Because you don't really, and then obviously the cholesterol and, those are more objective data. So first I'll kind of go through that with them and see. Now, if they have symptoms, then I think automatically they really should start getting on some sort of hormone therapy. I'm a big fan of transdermal estrogen. I'm really pretty strongly against oral estrogen for multiple reasons, because it goes to the liver, increases clots. There's so much mixed data about stroke risk and clot risk and, all of that. It's not as, I don't feel like it's as steady of a response in your systemic system because it's going through the liver, right, and getting metabolized. So you don't really know all of that. I just think it's not worth the risk of all the clots and all that kind of stuff when there's so many other ways to get estrogen nowadays, right? We're not stuck with one way. So personally, I will, if I write some recommendations down, it will be transdermal estrogen. And, there's multiple ways of getting it, whether it's the patch or the gel or the ring or, and then usually oral progesterone is what I'll recommend, especially if they have a uterus. You have to be on progesterone with the estrogen. So I'll usually have them take some oral progesterone along with it. That's usually my recommendation to kind of start with, right? To see where they're at and how they feel, especially symptom wise. And then maybe recheck their cholesterol, see if it, to me, I don't think estrogen therapy or progesterone or hormone therapy directly helps weight loss. I don't think there's I haven't seen it. And I think data doesn't really show that it's directly helping weight loss, but there are indirect effects, right?
Yes.
If you're sleeping
Absolutely.
better, right? And your brain can think and you're not exhausted, right? I mean, there's so many things of all of that. So you feel like actually exercising, you actually want to eat healthier. So I think just being able to get some of those simple things improved will help indirectly with the weight loss. But if someone comes to me and says, hey, I just want to be preventative, right? Like I don't have any symptoms of menopause or perimenopause yet, right? Do I take this for prevention? That's where the data is very tricky. And I feel like women are so understudied. Like, I'm sure you guys already know this, but there's just not enough studies, right? To say, I mean, if you look at the guidelines, they clearly say there's no indication for primary prevention for heart disease. I mean, come on. There's got to be, to me, right? Like, how is there not? We know that when you put patients on transdermal estrogen, their blood pressure goes down. Their insulin sensitivity improves.
Cholesterol.
They've even seen it in the cholesterol improves. Their carotid arteries, you can see less plaque buildup, right? And those are all the studies are just kind of coming out in the past 5-6 years, but they're still not in the guidelines yet,
So going back to one of the things that you mentioned about heart attacks and women presenting differently, this was also something that I just became aware of as well, is what are the symptoms then for a woman that is having a heart attack or about to have a heart attack?
Yeah. So traditionally, heart attack, whether it's a man or a woman, right? We always are talking about, okay, there's an elephant kind of sitting on your chest, a heaviness, a pressure kind of feeling. That's an acute heart attack, most likely, right? Now, the other things that can go along with that are getting sweaty, nauseous, throwing up, going into your jaw, going into your jaw
thing.
So those are all kind of
the jaw thing that I heard.
And some people just have jaw pain, right? And they think it's TMJ or something like that, but it's actually, a heart attack. Now, what I will say, I know, I was like, what? But this is what I'll say.
No, like this week I've had jaw pain. And I'm like,
checked out.
Go on.
But so this is what I'll say. So two things I'll say. One, right, if you're feeling, like if you're all sitting there and all of a sudden you're feeling this, okay, you need to go get checked out, right? But you don't want to also be kind of what you were saying before, Cindy, like, well, every 2 seconds, I don't want to go to the ER because I'm having jaw pain or belly pain or chest pain. I mean, right? There's billions of reasons why people can have chest pain. Obviously, the heart is what we want to make sure it's not, right? But there's so many reasons. So the way I explain it to patients is like, listen, if you have that sudden onset of heaviness, sweating, jaw pain, you're winded, go get checked out.
And it's not going away?
And it's not going away, right? It's not going away. Usually, I very rarely have seen. Now, seen some people who don't go to the hospital. They survive their heart attack. They come in like a month later, like, oh yeah, so like a month ago, I had this weird thing, and I'm like, oh my gosh. And they did. They had a heart attack. They had no idea, whatever. Because people can survive heart attacks too. So the second thing is ongoing. So let's say you're used to walking 3 miles a day, right? And you're fine, no symptoms. But then for the past 6 months, I'm a little bit more winded when I walk. I'm a little bit more short of breath. I'm more tired than I used to be, right? So that's where I educate my patients. I'm seeing you once, right? Maybe every 3 months, maybe every 6 months, right? You know your body better than anyone. If you've been winded for 10 years, okay, you haven't been having a heart attack for 10 years, right? If you've been tired, the same tired for so long, yes, get checked out, but you probably haven't been having a heart attack for 10 years, right? But if there's a change, right? So the change is where I tell people to pay attention. You know your body better than anyone else. So listen to it. So if you're feeling like, I used to be able to do this, and over the past year, I'm kind of feeling this slow decline, and I don't know if it's just because I'm getting older, I'm not sleeping, am I more stressed, but there's definitely a change in what I can do and how I feel. That's where I would say, let's get everything checked and make sure it's not heart disease.
Which is going to lead into a heart attack.
Which can.
Okay.
Yes, absolutely. Yes. And so going back to like cardiology 101, right? So when you look at, my patients who actually come to me like that, how I just described it, right? They're like, okay, I used to run 4 or 5, and some of these, as you know, like more and more 50 and 60-year-olds are like 30-year-olds, right? They're running marathons and they're doing all these things, right? And some of these are very athletic people who they're used to running 6 miles, but now when they run 5 miles, they're a little bit tired. Okay, well, you just still ran 5 miles, right? But it's a change for you. And so my patients who have a stable symptom, which is what I just described, meaning they were fine, normal, right? And then they kind of slowly have this kind of decline. Something might be going on. Those are actually a little bit of my easier patients to say, you know what? You might have a blockage that's 70, 80%, okay? Because it's a supply and demand issue at that point, right? It's because you're trying to exercise and get your heart rate up. Your heart is a muscle. It needs blood flow. If there's an 80% blockage, you might be fine at rest because you don't need all that blood flow. But the minute you start doing something, right, to a certain level, then that supply and demand issue is there. Okay. So those are actually my more, if we have to do a catheterization, go up, put a stent in, get the blood flow back to normal, right? Those are actually a little bit easier to diagnose. Now, the harder patients and the more complicated patients, and what everyone's afraid of, is people can run around with a 20, 30% blockage and have no idea that they have it, right? They're going to pass every single stress test, right? Stress tests are not designed to be abnormal unless you start hitting a certain threshold, like 60, 70, 80%. So very often, people are like, well, I passed my stress test, I'm fine. Maybe, I don't know. You could still have a heart blockage that's 20% that if it ruptures in a second, that 20% goes to 100%. Those are the people who they were fine and then they just died, or they were fine and then they just had a heart attack. They didn't have any of those leading up symptoms like we talked about. I've been more tired for 6 months. They are fine and not fine because a 20% blockage all of a sudden goes to 100%.
Okay.
Right. So those are the patients I'm trying to get more aware. To me, knowledge is
preventative,
right? What is going on with your preventative? What is your heart arteries? What does it look like? What can we do about it if you do have a 20% blockage? You can live with a 20% blockage your whole life. Well,
How does it go from 20 to 100 like that?
Great question. So if you imagine a pipe, right? An artery, heart artery, a pipe of water flowing, blood flowing, whatever. If you've got a bunch of rocks and sludge and all that, but it's not, your water's still going, like you don't even know that there's rocks and sludge in there, right? If that sludge all of a sudden breaks up, right, and then you get a bunch of sand pebbles on it and all of that, that's kind of akin to what happens in a heart attack. So what happens in a massive heart attack or a heart attack is all the cholesterol plaque that's kind of contained in that little 20%. There's all kinds of things in there, right? Cholesterol and inflammation and, clotting factors, all kinds of stuff that's just hanging out. If there's a little tear, and there's a cap that protects all that, it keeps it kind of down there, right? If there's a little tear in that cap, there's nothing to contain now. All that stuff that's in there, where is it going to go? It's going to go out. So it goes from 20% to 100% in a matter of a second.
Okay.
Right? So our goal as cardiologists is like, how do we keep that? Two things. One, how do we keep all the junk, plaque, cholesterol, inflammation markers at bay, number one, so it doesn't keep growing. And number two, how do we keep that cap from exploding, right? Like a volcano. Those are that's why people are always, cholesterol, don't smoke, diabetes. What are the traditional risk factors, right? Smoking, being diabetic, having high blood pressure, cholesterol, right? It's a loaded discussion. Family history can be one, right? There's lots of different factors. Stress is a huge factor as well. So, and then women, when you add women and then the lack of estrogen, which helps actually with the inflammation and all that, and then you lose it, right? They're just another factor now that you add for women especially. So we as cardiologists are trying to how do we, again, back to defensive medicine. Oh, well, you don't have any symptoms. You're fine. I'll see you in a year. Whereas proactive medicine is, well, let's look at your heart arteries. Let's look at all your cholesterol. Let's look at all your risk factors and do whatever we can possibly do.
Question about the estrogen again. So seeing a woman who is like our mom's age, so, late 60s, early 70s, who has clearly been affected by not taking HRT because of the whole WH, right?
Yes.
What do you do then for women who are of that age who never got the opportunity to use estrogen, to use HRT, and now they're at this point where obviously they don't have any estrogen and their heart is clearly going to be affected or is affected?
Or even women our age, I suppose. Would it be different if they're, 70 or 80 or 40, 50, 60 who can't take HRT? Because not everybody can and not everybody chooses to. So it's true. Dr. Mona.
What do you do?
Yeah. So as far as if you choose not to, so what's the question if you choose not to? So let's talk about age first, right? Let's say both ages are willing to take HRT, right? Who is it going to benefit? Who is it not? Really, if you look at the data, there's a whole timing hypothesis, right? Which I really believe in, is that you really want to start women. It's the amount and length of estrogen depletion, that the years kind of add up. So starting hormone therapy at really 60, 65 and up, I'm not quite sure how much bang you're going to get for your buck, right? I don't think we have enough information, to be honest with you, if starting someone at 65 is going to prevent heart disease. Now, if they're on it for symptoms, that's a whole different story. But just starting it on it for prevention of heart disease, I think we've kind of missed the boat by the time they're 65. Now, obviously, there's data on, vaginal estrogen there's good data for preventing, UTIs and a lot of other issues that can happen as we get older, right? One of the most common things that happen as women as they get older is chronic urinary tract infections. Because the tissue's kind of degraded in our pelvic system. So that's a different thing. But as far as the heart goes, I would be very hard pressed to start a mid 60-year-old on hormone therapy.
So then what do you do?
Now, I mean, you try to attack their heart disease from different angles, right? Because it's not just, I mean, even what do I do with a man, right? I mean, so I just try to treat them from all the other angles. Let's talk about diet. I mean, diet's huge, right? For inflammation. Let's talk about your stress levels. Let's talk about what vitamin supplements you're on. Let's talk about your exercise. What are you doing? There's a lot of different other things we can do besides just hormones. But even my women who I put on hormones, I'm still talking to them about your diet. And
it's not the end all be all.
It's not a magic cure.
Right. It's not a magic cure. And for women who are 40s, 50s, who don't want to be on hormone therapy, okay, that's fine too. Then we just attack as whatever we can. Again, there's not one thing that causes heart disease. It's not that, okay, you're a woman, you don't have estrogen. Well, that's now we're
Yeah.
Right.
Too bad. No, there's millions of things, right, that we need to attack it from all different angles for heart disease. So then we attack everything else that we were talking about.
Okay. So then what are the top lifestyle factors to help protect a woman's heart?
Right. So, diet's going to be a big one, right? That I'm always going to talk about. And I'm not talking about being on a diet. I'm talking about food, nutrition,
What are
right?
the
Food that
top
comes
ones for
into
you? Fiber?
fiber. Yeah. So fiber, I always try to aim people to get, it's shocking. So I have patients use my Fitness Pal and I'll look at it and whatever. And it's shocking how many people just don't get the fiber, right? If I have my way, I'll tell them try to at least get 25 to 30, that's kind of a good goal to get. So fiber is huge, and protein, right? So protein for women is important. You guys, probably already know that. And then at the end of the day, it's low sugar, right? Low inflammatory foods. Now, as far as, so I break it down with patients into fats, proteins, and carbs, right? So if we talk about fats, I'm always going to push mono unsaturated fats, which is your avocados, your olive oil, your avocado oil, unsaturated fats like nuts and Mediterranean style, right? So if you look at kind of the data for lifestyle in general for anti-inflammation and prolonged living and heart health and stroke health and all the stuff, Mediterranean always keeps coming up over and over and over again. And so those are the kind of fats I talk about. When you talk about protein, that's an interesting one because, some people are very into their meat and carnivore. Some people are vegan. Some people are, it's all over the map, right? My general nutrition for, counseling for this is Mediterranean with fish, right? And so if I, tell a patient, like, listen, if you're going to pick a protein and you have a choice and you like all proteins, pick wild fish as opposed to, red meat or chicken or any of that. And why, right? So any sort of meat, poultry, red meat, chicken, pork, whatever, is all saturated fat, right? So saturated fat, we all need fat. We all know that. Everyone needs fat in their body every day, right? But the problem is when you look at how much fat you're supposed to have in a day, let's say it's this, most people are having like a lot more saturated fat than unsaturated fat. Fish is unsaturated fat, okay? So,
But why
I'll try to
would people
encourage that.
think or that chicken breast is more healthy than other forms of meat?
So
Would it
why
be?
would it
Is
be
it better?
better?
Yeah. Or is that, nah?
I mean, to me, at the end of the day, I mean, obviously, I'm not even talking about processed meats. I'm not talking about like
Yeah.
hams and cold cuts and all that processed stuff, right? So definitely for that, I tell patients like, listen, if you absolutely need bacon and sausage and cold cuts and hams, like just do it. I'm an 80-20 person. So it's got to be
Right.
20, right? Have it once on the weekend, have it every other week, whatever. So that's the processed kind of meats. But then if you focus on like, grass-fed beef or free-range chicken and all that kind of stuff. To me, it's portion size, and again, it's saturated fat. So it's not just the saturated; it's additive, right? Saturated fat. So if you throw in some chicken, then you have some butter, then you have some cheese, then you have. I mean,
Okay.
it's all
Hmm.
adding up. It's not just you ate chicken today. That's a
Yeah. Yeah.
problem. Well, if that's the only saturated fat you had for the day, okay. And also what's interesting, talking about the gut is, and I tell patients like, I had a couple the other day that they're married, they're in the same house, they eat the same thing, right? Very, very carnivore based, right? And I said, okay, let's do that. And they both had high cholesterol. They both had plaque in their heart arteries. They didn't want to take drugs. So I said, okay, let's do this. Let's get there's a blood test called TMAO. And what it is it kind of, it's a byproduct of your gut and how it handles animal products.
I'm writing this down.
And yeah, TMAO. Don't ask what the whole name of it is. It's like something methylated, blah, blah. But it's basically your gut's way of handling in your body animal products, animal proteins, and your gut bacteria. Okay, so, so this couple, the woman, her TMAO was through the roof, right? The husband's was not. So I said, you know what, for you, I mean, if I cut out your animal products, maybe for different reasons, but not for your cholesterol, it's not going to make it. He had a very bad insulin sensitivity problem. So we had to work on that with him. But for her, she cut it out. I mean, she just became the best vegetarian around because she hated fish, and her cholesterol numbers
Amazing.
dropped, right? And I didn't have to put her on anything. Yeah. But again, so again, back to being holistic and looking at the whole body, it drives me bananas when I hear podcasts or articles like everyone should be carnivore, everyone should be vegan.
Yeah.
No, I don't know. Your body, your genetics, your gut bacteria, there's so many things that make up what's happening in your body. Maybe
Right.
not, maybe. So that's, my whole thing with proteins. I'm always going to try to push more vegetarian/fish. And then you go to carbs, right? I mean, carbs have been all over the map, right? So, and, I personally am not a fan of the whole keto diet because most people just do it completely wrong. I can actually walk into a patient's room and I'd be like, I know you're doing keto. They're like, how do you know? I'm like, because your numbers look like terrible and you're super inflamed on your numbers, right? And most people, they can't sustain it, right? I mean, there's a few people who can do it. But anyways, carbs aren't bad, right? The problem is portions, right? People just eat this much of their pasta. But if you really look at a serving of pasta, 2 ounces, and you actually weigh it, I mean, it's a decent size, but it's not a lot, right? So anyway, and if you're going to pick carbs, look at, and that's where the labs come in, right? So I always check insulin sensitivity, like what's going on in their bodies with their insulin levels. And of course, women, once we hit our 40s and 50s, are either eating the same thing, but our bodies are not responding the same because estrogen's gone, insulin sensitivity tends to go up. So I like to check insulin sensitivity. And if I see it very high and pre-diabetic levels, right? Because A1C is a test that people check to see where are you with your sugars over a 3-month period. Okay. It's a good test. It's a great test. It's a standard of care, right? For if you're diabetic or pre-diabetic, and there's levels to be diabetic and pre-diabetic. I like to get insulin sensitivity, which is even another layer of pre-diabetes, right? Like I want to catch if your insulin is going high and it's going to start becoming dysfunctional, I want to catch it ahead of the time, like before the A1C starts climbing up and we're in this diabetes range. So back to carbs, right? So, there's no standard, like, oh, everyone should get 100 grams. I don't know, maybe not, depending on what you're doing for exercise, depending on what you weigh, depending on what your other things you're eating. But in general, I try to have, try to get your carbs from fruits, veggies, more whole sources as opposed to processed, right? And then sugar is the other piece, right? Less added sugar, of course.
Right.
So.
Okay. Cynthia, I'm going to let you take it from
Okay. We're going to talk a little bit about screening and testing and intervention.
Yeah.
So we've talked a little bit about cholesterol. Is that the test we should be asking for, or are there other tests we should be having?
Great question. So number one, if you start from the top, right? So everyone should be knowing what their blood pressure is, right? So when you go into a doctor, obviously they should be checking it. But if you're only going to the doctor once a year, I mean, that's probably not enough to know what's going on. High blood pressure can go silent, right, for many years because you might not even know that your blood pressures are high, right? So ideal is 120/80. That's ideal. But I have some people who are, 135, 138, on the top number. And you're not going to feel that. For the most part, most people don't know that they're running that high. And how often do you go to the doctor's office and give white coat, right? You're high, you want to be there, it's going to be high just because you're agitated. So I'm a big proponent of get a blood pressure machine. They're like $50 on Amazon, right? Check it once a week, right? Like, so that way when you do go to your doctor, if it is high, you can say, well, I check it at home and it's this, right? As opposed to, well, if it's high in the doctor's office, the doctor might say, okay, you get a drug, okay? But it's not really even high. You might not even need it, right? So anyway, blood pressure, know your blood pressure, right? It's such an easy thing. Throw it on once a week, check your home ones. So cholesterol, right? So cholesterol, traditionally, a regular cholesterol panel, right, has a total cholesterol, the HDL, which is the quote unquote good cholesterol, which yes and no, triglycerides, right, that's your carbs and your sugars, and then you have your LDL, right? And so, but nowadays, and LDL is considered the bad cholesterol that you want to keep down, right? And so because we know that in some people, higher LDLs, remember we talked about that plaque and all the junk and all the stuff in the arteries that cause plaque. Part of it is cholesterol, the LDL cholesterol, right? But that is just one piece of the puzzle, right? If you look at more data nowadays, and I really feel like more cardiologists especially, and some primaries are doing it now too, we need to look at the bigger picture for cholesterol, okay? Because LDL to me is one number that I'm looking at for you. I can have two people with the same LDLs, right? Maybe a little bit high, maybe borderline, but if they're eating completely different, if someone's eating McDonald's and Arby's and this other person's eating completely clean, and they both have the same number, am I going to treat them the same? Like, is their LDL look the same? Maybe not. So I pretty much on every one of my patients, I get what's called an advanced lipid panel. That looks a little bit deeper at the cholesterol, right? So it looks at if your cholesterol's sticky, is it inflamed? There's other markers like ApoB. So ApoB, so LDL is just one of the cholesterol particles that can cause plaque. There's IDL, there's VLDL, there's all kinds of DLs, lipoprotein A stuff floating around. ApoB is on all of them. So yes, I want your LDL to be low, but I want your ApoB really to be low as well. And then there's CRP, which is a marker of inflammation, right? And so in some women, when we lose estrogen or CRP, our inflammation goes up. So I'm always checking that. And I'm always checking lipoprotein A. So lipoprotein A is a genetic protein that attaches itself to the LDL and makes it at 4 to 5 times higher risk for heart attacks. And it's genetic. You either have it or you don't have it, kind of thing. So that's so to answer your question, once I get that once on a patient, I don't get it maybe every single time. I'll get it maybe every couple years. But I kind of have an idea of, okay, this is what I'm looking for. This is what's going on with your cholesterol. It's sticky, it's inflamed, or you know what? Your LDL is really high. Because I get all the people who don't want to be on drugs, right? They're like, oh, my doctor wants me to put me on a statin. I don't want to be on a statin. Right? And so then I'm like, okay, well, let's look. So I'll get the advanced lipid panel and say, okay, if you have a high LDL, but it's not sticky, it's not inflamed, and then I'll get a scan as well, which we'll talk about, and you don't have any coronary disease, I'll watch you before I put you on anything. I'm always going to talk about diet no matter what. I don't care if you're on drugs or not drugs, you're always going to get a nutrition consult from me. But to answer your question, so that's, I think, very important, that the basic test should include an ApoB, a lipoprotein A, and a high sensitivity CRP.
And we would probably have to ask for that.
For cholesterol, yeah. Yeah, I mean, unfortunately, it should be really standard of care, but it's not yet. So I have cardiology partners who don't even know it. So, so it's not there yet. And then the insulin sensitivity test, right? I think that's important to kind of what are your insulin sensitivity and insulin resistance is huge marker of, it's a huge cause of inflammation, right? Inflammation at the end of the day. So yes, you have all this plaque sitting in there, but what's happening? If it tears, you have all these inflammation markers coming on top of it, right? And platelets that are sticky. So insulin resistance, if we develop insulin resistance, which is pre-diabetes, pre-diabetes, it's a very high marker of, risk of coronary disease, lots of things. Okay. But for the heart is, coronary disease and stroke is a huge one for insulin resistance.
Is that a blood test?
And then
we can, okay.
Yeah, it's a blood test.
I don't think I've ever had that done.
At the minimum, at the minimum, get a hemoglobin A1C, right? All doctors know what an A1C is, right? Because that's how you know if you're diabetic or pre-diabetic. So that's at the minimum, right? Because remember, when you get your labs test and you get a glucose, right? Again, that's like your blood pressure. That's a one moment in time of what you're right? It doesn't show like a bigger picture. So the minimum is get an A1C periodically, and then if you want to go deeper, you get the insulin resistance test. Right. And then those are the main labs I order. I do order homocysteine too.
Great.
Which I don't know if you guys talk about MTHFR gene. So homocysteine, MTHFR is a gene. It's genetic. If you have abnormalities in that, you're more prone to high blood pressure, clotting, stroke risk, all the stuff, right? I sometimes will get the MTHFR gene itself. Insurance companies are kind of all over the map if they want to cover it or not. I sometimes just go directly to the homocysteine level, right? So if you have an abnormality in your MTHFR gene, your homocysteine levels are high. So, and it's very easy to treat. So it's treated with a supplement. So high homocysteine is one of the other things I mean, homocysteine levels are another panel I check. Again, labs, right? So homocysteine, CRP, lipoprotein A, ApoB, your lipid panel, A1C or insulin. Sometimes I'll throw in an omega index, an omega check to see if you need omega-3s or maybe you're getting enough from food. Not everyone needs omega-3s. I'm trying to think. Those are kind of the main, cholesterol type of, besides the regular thyroid and all that kind of stuff is standard of care to me. That's labs. And then as far as, we talked about blood pressure, and then as far as, testing, right? What kind of scans and kind of stuff can we do, right? So calcium scores are do you guys do calcium scores down there? Do you know, like a scan?
I don't,
do you have,
I'm assuming they do.
Doesn't sound familiar to me, but yeah, it doesn't mean that they don't do it.
I'm assuming Health City does.
So
again, it's something we'd have to ask for probably.
Yeah. So it's a simple scan. It's literally a CAT scan. There's no dye given. It's very little radiation. It's like literally a 5-minute test. Okay. Insurance companies don't even cover it. Here in America, they run about $100. Okay. But what it is it's a quick scan, CT scan that looks at if you have plaque or not. Okay. Do you have plaque or not? Right. Now, the caveat is it's a great screening. If you're going to have anything, right? Okay. Get a calcium score. Like that way you would just know. Do I have any plaque or not, right? So it spits out a number. 0 means no hard plaque. And we can talk about the difference in a second. 0 means no hard plaque. Above 400 means significant plaque. And then you're graded to your age, right? Obviously, a 50-year-old compared to a 70-year-old, you're not going to have the same risk depending on what your score is. So that's a very great scratching the surface. Do I have plaque or not? Now, when you're younger, right, and I'm talking... I don't very often order it in my 30-year-olds, maybe 35 if they have a very strong family history. 40-year-olds I'll order it on, definitely 50, 60, 70, etc. The reason I don't order it as much on my youngers is because it's calcium deposits, right? So it shows us the hard plaque. It does not show us the soft, mushy, all of that stuff, right? What causes heart attacks? Soft, mushy, all of that. But we know if you have hard plaque, you have some soft plaque. But the question is we can't see it on the calcium score because it's just the basic level test. We know you have some, who knows how much. But we're going to treat you like you have it, right? You have a calcium score, that means you have blockage. We're going to start treating you more aggressively with X, Y, or Z. So the next level test, right, is a coronary CT, which actually you get an IV, you actually get contrast. It actually looks at all the heart arteries like in detail. This is the percentage of blockage and this is where it is. And this is soft plaque and this is hard plaque. So it's a lot more in detail, right? Then the next level test that I often get is they get the CT and then I add Clearly, which is with 2 E's, AI technology on top of that. So it's AI and it basically looks at the plaque even more. Okay, it's very, very soft. It's kind of soft. It's very, very hard, right? So it's an excellent way of kind of knowing what am I dealing with, right? So if I get a 35, 40, 50-year-old who has no symptoms, they're exercising, they think they're eating pretty good, hey, I just want to know what my risk is, like what's going on, right? Or if they come to me and say, hey, my cholesterol is a little bit high, but I don't necessarily want to take drugs yet, do I need to, et cetera. I'm like, okay, this is what we're going to get. We're going to get that advanced lipid panel like we talked about, all those labs, and I'm going to get a coronary CT on you because I don't want to know if you have hard plaque. I want to know more. Do you have soft plaque, right? That's your danger zone. And then if we can add the Clearly AI on top of it, that just gives me a bigger picture of this is what's going on, right? If your arteries are crystal clear, you've got nothing going on. If your cholesterol is high, what am I going to treat you? Why? You don't even have any plaque, right? But on the flip side, I've seen so many 40-year-old women, and 50-year-old women who have soft plaque and their calcium score was 0, right? They had no hard plaque, they have soft plaque. And then, I had a woman a couple of years ago who had a 0 calcium score, high cholesterol, 0 calcium score, wasn't treated, and she had a massive heart attack, right? Survived, right? Because it was all soft plaque. So to me, I'd rather go for the money shot, right? I want to know, And insurance companies cover it sometimes. Here, you can get it for cash price, like 400 or 500. So a lot of patients are like, well, if I'm paying 100 for just a calcium score, I'd
Yeah.
rather pay a couple hundred more and know more information.
Now, the women that are getting these tests done, or that you're recommending getting these tests done, are
Yeah.
they coming in with high cholesterol scores or not feeling great? Like, or are they coming in feeling fine but want to know more about their heart health? And is there a
More,
recommendation for who should
yeah.
be getting these tests done, I suppose?
So I see all of it, right? The majority of patients who I see are ones who have a little bit of risk. Maybe their cholesterol is kind of, like I said, like a lot of patients don't want to get on
Yeah.
drugs, right? And so they're coming to me saying, well, what else can I do? Can I take supplements? Can I fix my diet? I said, maybe we're going to definitely work on diet. Maybe supplements will work. Maybe they won't, but let's know more, right? And they feel fine. They have no symptoms at all, but they want to get checked. They don't, because remember, sometimes the first
Yeah,
symptom is the
right.
heart attack or the stroke, right? So they want to kind of avoid that as best as possible. So in those cases, right, I'll get that advanced lipid panel and the CAT scan to look at the heart arteries to kind of get a better idea of what are we dealing with risk wise, you know. And if patients do have some symptoms, I'm still probably going to get their labs for sure, because I just kind of want to see, and then maybe I'll get depending on how bad their symptoms are, maybe I'll get the CAT scan. If I'm really, really concerned, I'm sending them straight to the cath lab to go look and see if they need a stent or something like that. You know, yeah. So,
All right. Yes,
that answers your
definitely.
question. Yeah.
I'm going to switch gears a little bit now and talk about mind body. How do emotions, trauma, chronic burnout, how does that typically show up in the heart?
Yeah, so if you look at the stress response, right? I mean, I'm not talking about a big stressor like, you know, loss of a child or something. I'm talking about the chronic day-to-day stuff that we all deal with, right? Now, just a caveat, like the big stressor, there is a thing called broken heart syndrome, Takotsubo syndrome. It actually, usually it comes, if you're going to have it, usually when people, it's not that common, but it can happen. And it's usually because of a massive stressor, like a massive stressor, right? Not someone took a
Right.
parking spot. I mean, so something bad really happened. And what happens is it's called broken heart syndrome because it looks like a heart attack. They come in severe chest pain. Their EKG looks like a heart attack. Their blood work looks like a heart attack. They go in to do a cath to look at the heart arteries, no blockage at all anywhere, right? And it's because that adrenaline, no one really exactly knows, but people surmise that the adrenaline rush was so much with that whatever that bad news was, that it caused a flood of adrenaline into the heart system, and it caused this heart damage. The good news about it is 90% of the time it's reversible. Within 2-3 months, sometimes in 5 days, we see their heart function back to normal. Again, that's a small portion. Okay. Let's talk about the chronic stress, right? So the chronic stress is the day-to-day stuff, right? You know, being a mom, working, if you work, you have kids, being a wife, if you have a spouse, just all this stuff. And what happens, right? We know that cortisol goes up, right? Cortisol is kind of streaming through our body, adrenaline streaming through our body. And what does that do, right? They've done enough research that we know now that increased stress and chronic stress goes down to the DNA level, right? The telomeres on the ends of our DNA, start shrinking and aging accelerates. As far as the heart goes, if adrenaline's up, you can imagine, when you're really frustrated, our faces get red, right? We get like whatever. So imagine what's going on in the heart, right? Even if low levels of it are streaming, right? Your blood pressure is going up. Your arteries are like constricting down. Platelets become stickier. Cortisol increases inflammation. Our immune system doesn't work as well. So kind of that whole, usually when I see chronic stress affect the heart, it's been a few years of just kind of chronic stress, right? It's just kind of going. That's when I see the heart effects of it. And honestly, the main reason I got into holistic cardiology was because of stress for patients. So often I saw so many women, men too, but a lot of women who were 30s, 40s, 50s, going into the ER with high blood pressure, chest pain, palpitations, and all the tests were fine, right? And then they're kind of left with, but I'm feeling this. Like, what's going on, right? Am I just crazy? Or because all the testing is fine. And it was very disheartening as a physician to say, all your heart tests are fine. I don't know, go see a different doctor, go see a psychologist, go see a primary care, right? And I was kind of going through things in my own life, and I was like, well, these are kind of similar to what, and I started, anytime anything affects you, right, you start researching everything because you want to know more, right? Same with me. When I went through perimenopause, I did every single kind of research on hormones and everything under the sun to help me, but to help my patients as well. And so I kind of started realizing that one of the bigger factors for all these women was stress. Like everything was fine. They were actually eating pretty good. They were exercising, but the stress was off the chain. And so more and more, I was like, okay, let's start meditating together. I'd start meditating with them in clinic, right? Like, let's just do that. Let me give you a prescription of meditation or breathing, whatever you want to call it, right? There's lots of ways. Finding your things that you can do for yourself, the whole self-care, the gratitude, blah, 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 all this stuff. And then I was like, we were getting better, right? They were coming off blood pressure medicine. They were feeling better. I put them on a few supplements like magnesium and vitamin D and just all these kind of little things, right, that they were so deficient in. And I'm like, wow, these patients are getting better with no meds, and they felt amazing. So that's when I said, I want to learn more. That's when I got board certified in it. But to answer your question, yeah, chronic stress is an equivalent risk factor for heart disease, just like high blood pressure and diabetes and all that. So. And it's not about getting rid of the stress, right?
Yeah.
Managing it.
The Dalai Lama probably has stress. It's managing it. Yeah. It's kind of finding that balance, right? And I feel like as women are getting older, they're doing a better job of finding the balance. Maybe because the kids are older, maybe because they're more settled in their life.
We finally put ourselves first.
Ones, right? Yes. It's the young ones, 30s and early 40s who have young kids and they're working and it's like, I'm trying to say, okay, if you do one thing in the week, do this, or wake up in the morning. I tell all my patients, first thing in the morning, I want you to think of 3 things you're grateful for, right? And small things, not like, amazing, just a little thing, right? That you're looking forward to that day or that happened the day before. And then I tell them, okay, take 10 slow, deep breaths. You want to imagine love and peace coming into your heart, and it flowing and it pumping, like visualize that, right? And then let the love and peace go back into the world. Just 10 times, and then start your day, get on your phone, do your doom scrolling or whatever you want to do, and get the kids and, all that. Because I said that, what I just told you takes less than 5 minutes and it's free.
Yeah.
Right? And so it definitely starts our brain first thing in the morning on the positive wiring, as opposed to, what we traditionally do is, oh my God, I got to do this and that. And I can't believe this is going, all the stuff that we do as human beings.
So that was my next question. If you could tell any of the women listening, just one thing that we could do to support our heart health, what would you tell them?
I think it would be a generalized awareness. Know your body, right? I mean, we've talked about so many things. I wouldn't be able to say, just focus on your diet, right? It's just know what's going on with you. Don't put your head in the sand, right? And say, I'm fine, I'll deal with this later, right? Go get checked, especially if you have a family history, right? Especially if you have even a little risk factor, especially if you're menopausal, perimenopausal, right? I'd rather you come to me and waste my time, quote unquote, than something happened because you were afraid of wasting someone's time, right? So it's about awareness. Know your body, know what's going on, know what your risk factors are. Do you have high blood pressure and you have no clue about it? Do you have insulin? Are you pre-diabetic and you don't even know, right? You're gaining weight, menopause. Where's the fat going? We all know where it goes in the middle. Are you holding on to visceral fat, which is an internal organ fat? Awareness.
Actually, one question then, the Oura Ring or the Whoop.
Yeah.
Are you a big proponent of those? Like in terms of data?
I have a Fitbit. I have a Fitbit. I have patients of the Whoop. I have patients of the Oura Ring. I think they're great. I think they're, well, one, I like, so when we haven't talked about exercise, but, part of this whole thing besides the stress and the food and then the supplements, the vitamins and all that is exercise, right? That's to me is a huge thing. But that's where I feel like some of the Oura, the Whoop.
Does it help you as a doctor when your clients have them?
Yeah, it does, because I can see what their oxygen is at night. I can see how they're sleeping. I can see how many steps they're getting. I'm a big fan of getting your steps and all that kind of stuff. And some of them have heart rate variability,
Yes,
right? So even the Fitbit now has heart rate variability. So yeah, so heart rate variability is important too. How do we fix heart rate variability? I mean, it's again, everything we just talked about, right? Exercising, sleeping, stress, but it's good. Knowledge is power, to me. So the more you know about yourself, the more you can make changes where it's necessary.
Okay.
Yeah. And then, yeah.
There are some, you've heard it out there. There's 34 symptoms of perimenopause. There's 80 symptoms. There's 100 symptoms of perimenopause. One of them, one that I've personally experienced, is heart palpitations, like heart changes.
Mm-hmm.
Should I, or anybody having that, or any of the other, hundreds of symptoms of perimenopause, dismiss that as perimenopause, or is that something that I should be talking to my doctors about?
Good question.
Yeah, that's a great question. So palpitations, heart skipping, heart racing, fluttering, whatever you want to call it, is very common, especially when we go through different parts of our life as a woman in our cycle. Like I have a lot of people who they get pregnant and they start getting all kinds of crazy palpitations. The minute they deliver, they go away, or vice versa, right? But we know it's because of, or right around their cycle, they get crazy palpitations for those 3 days before, and then they're fine, right? So we know that there's definitely a hormone relation in menopause, where we are in our life as a woman, our hormones are up and down depending on where we are. But to answer your question, yes, I definitely think, if someone comes in and says, I get a skip here and there every couple of weeks, I'm like, okay, that sounds like it's just kind of part of the norm, right? No one's heart is beating 100% normally, right? We all have extra beats here and there. Some people feel them, some people don't. But if I have someone that says, I'm feeling a little bit more, I'm uncomfortable when they happen, I will do a monitor on them to kind of see what's going on. Are these just extra beats, or is it you just feeling them, but they're actually normal beats, right? Because sometimes we can think we're having fluttering, but when I actually look, I'm like, we don't have any fluttering. Or they're actually having extra beats, right? And then if they do, I always will check vitamin levels. I'm always checking thyroid. Are they anemic? What's their iron? What's their D? What's their B? How much caffeine? How much alcohol? How much sleep? There's so many things that go into why people can have palpitations. 90% of the time, 95% of the time, they're benign, meaning they're not going to kill you. They're just super annoying, right? But I always want to make sure that you're in that 95%, which is hence I'll get a sonogram of your heart, make sure the heart functions good, the valves are good, and I'll get the monitor, right? And then I'll check all these labs to see where you are. And then I traditionally put patients on magnesium because I feel like it solves probably 80% of my patients' palpitations.
Amazing. Glycinate. Magnesium glycinate.
Well, and there's so many different types of magnesium, right? I love the glycinate. If someone's more stressed out, I put them on threonate. If they have high blood pressure, I put them on taurate, right? Magnesium, there's so many different ones. But yes, some sort of magnesium, most of the time in my patient, fixes the problem, right? If it doesn't, there's other supplements I can use to help lower it. Because I hate to put patients on medications just to lower symptoms when it's not going to kill them. Like I tell them, I said, listen, if you're really symptomatic, I can give you a medication, but these palpitations are not going to kill you. So medicine is not going to make you live longer, right? So then usually they're like, I don't want it.
It's
I'll
just
deal with it. As long as I know
it's just a funny feel. Like it can be scary, and it's sometimes takes your breath away a little bit. And I think it's more the scare because you're like, oh my gosh, is there something wrong with my heart? So it's a bit scary.
Well, and that's where I would say start doing a diary. If it's a day that it's worse, how much alcohol did you drink the night before? How much did you have more caffeine? Did you not drink enough water that day? Right? And electrolytes, right? We need electrolytes, especially for sweating and water. And then are you more stressed out than normal for whatever reason, right? Kind of look at those kind of factors, right? First. And because a lot of patients, when they start actually paying attention, they're like, oh yeah, that third glass of wine, boom, I get palpitations, right? Or or I can have one glass of wine, but that second one pushes me over the edge, kind of thing. So it's again back to awareness. Definitely. Know your body, know what it likes, know what it doesn't.
One question that I have, and I know that we're almost out of time, but just in regards to supplements and vitamins, because I do hear it a lot because I consult and I do DNA testing, and calcium supplements, calcium pills. What is your thoughts on it? Okay,
I
good.
don't like it.
Good.
My short answer is I'm not a
Yes.
fan. So, because if you look at data on calcium in pill form, right? Calcium in diet, actually very beneficial
Yeah.
for the heart, right? Calcium in pill form, not so much, right? Because where's it going? You don't know if it's going to your bones, right? It could be going wherever, right? So I traditionally try to get people off of calcium, right? What's more important to me for your bones and your heart is
Yes.
the D, the
Yes.
K2, and the
Yes.
magnesium, right? So those three. Now, if someone comes to me and says, "Oh my gosh, my endocrinologist, I have to be on calcium," like they're, it's like sometimes I fight with the endocrinologist because I'm like, they can get calcium in their diet, right? Vitamin D, very
Yeah.
hard to get. I mean, you can get in the sun and so many other things, right? Magnesium, hard to get. K2, absolutely hard to get, right? Calcium should be easy to get. Even if you're vegan and don't have dairy, there's so many sources of calcium. To me, you should be able to get enough in their diet.
It's
But even if they say, I have to be on calcium, I'm like, okay, fine. But then at least get more of a natural based one, maybe an oyster shell one, but you have to take K2, right? Because K2 is kind of an escorter of calcium to make sure it goes into the bones.
I've just found it's become a very common theme with women who are in like late 60s, early 70s, and typically getting a doctor that maybe a bit more old school, and the common theme is, oh, just take a calcium supplement.
Yeah.
Yeah, I've seen it a lot. So just curious.
Yeah.
Okay. Okay.
Not a fan. Not a fan.
I think that's all we have for our questions. Is there anything that we missed that you think we should know?
I think, well, I was just going to do a quick thing because I get a lot of questions about exercise and, all that kind of stuff. And maybe you guys already, but I would say, if I had met with women specifically, right? If we're talking about women and perimenopause and menopause and exercise, I mean, the three arms, really four arms, but really the main arms I talk about with exercise with my patients is one is weight training, right? Some sort of resistance training is really important. Because a lot of women, I don't know what your guys' experience is, they love cardio, right? I feel like. So I feel like weight training is an important one that a lot of women don't do, to be honest with you. And not just for heart health, but there's actually good studies for resistance training and cardiovascular disease, besides the bone and the muscle mass and, all that kind of stuff. So weight training is important. I think really the cardio, I push people away from the long and steady state, stuff. Unless, they're doing it for fun or they're training for a marathon or something like that. I kind of push them away from it. I am a big fan of NEAT, the NEAT, which you're trying to get the steps in or, whatever. What you're doing besides the half an hour you're exercising in 45 minutes. And then HIIT. So HIIT is very important for multiple reasons, bone health, but also cardiovascular, right? So even if you do it 2 or 3 times a week, 15 minutes, it's really good. I'd rather people do HIIT and then walk 10,000 steps and do weights instead of like, I'm going to throw an hour of exercise.
Yes. And
or running.
And there's also a correlation with HIIT as opposed to, let's say, a 60-minute spin or an hour boot camp, because it doesn't put your body into that stress state. You don't dip into that stress state.
Well, and if you do, though, right?
Exactly.
Short time,
yes.
Right. You're not like in this. So when patients are like, yeah, I did HIIT for an hour.
No.
Like, no, you didn't. And if you did.
Exactly.
Yeah. If you do HIIT, like I do HIIT, I'm done. Like after 15 minutes, I'm like, I don't want to do that. I'm done. I can't do this anymore. Right. That's how it should be.
And the stress state is hard on the heart and trickle down effect.
Right. And then if I have the fourth arm, I'll say do yoga, do some Tai Chi, do some of that kind of brain relaxing stuff.
Nice.
That's it. That's the only other thing I kind of wanted to plug is exercise.
Definitely.
This has been so good.
Yeah. This is really fun.
Yeah. This is great. I love talking about this. This is my favorite stuff to talk about. Literally.
I think it probably gets missed a lot. Like, I think I just assume that my heart is fine because I feel fine. So this was very, very informative, especially in midlife. How can people connect with you if they want to learn more, or if they're interested in coming to see you at One Heart Cardiology?
Yeah. So my website is my name, drmonashah.com. That's my website for my practice. how I practice, everything's on there. I have a blog too that I write articles periodically about everything we just
Oh,
literally
amazing.
talked about, right? Supplements, vitamins, diet, stress, what heart disease is, what a calcium score is, everything we talked about, but I've written like specific articles. That's on my WordPress page, which is WordPress, drmonashah.wordpress.com. And then I have Instagram too, which is Holistic Heart Doc. I'm not as great about that. I'm trying to get better. It's a lot to do Instagram posts, but anyways, I have my Instagram. I am on there. I'm trying to be better about it. But my blog, I focus on my blog a lot, just kind of writing little articles.
Great.
All right, that's great.
That's the main way.
Well, thank you, Mona.
Thank you.
We appreciate it.
To connect with you again.
Thank you.
Thanks for joining us on Breast Intentions. We hope you felt seen, supported, and maybe had a few laughs along the way. Don't forget to share, subscribe, rate, and review us. Your support keeps the conversation alive. Follow us on social media for more insights, behind-the-scenes fun, and updates on future episodes. Got a topic you want us to dive into? We'd love to hear from you. Remember, life's too short for bad bras, toxic relationships, and kale you don't actually like. So until next time, stay bold and keep your breast intentions exactly where they belong, front and center. Now go crush midlife, or at least today's to-do list. Cheers!